We're going to move on to our next session speaker, who was also present for the molecular tumor board at the last session, Catherine Skefos, who is a genetic counselor at MD Anderson in the Clinical Cancer Genetics Program, where she specializes in providing cancer risk assessment counseling to adult and pediatric patients in the Enterprise Center. Prior to becoming a genetic counselor, she received her master's degree in medical anthropology from the University of South Florida, where her research focused on healthcare access and health disparity. Catherine has a special interest in teaching, particularly educating healthcare providers about the utility of genetic counseling and testing with the goal of improving patient access to genetic services. So please join me in welcoming Catherine.
Thank you so much for inviting me to speak today. I'm going to be speaking today about some success stories, but also the ethical considerations that we want to think about when we're talking about germline testing and cascade testing in pediatric patients. Kristen highlighted some of the meaningful indications for genetic testing for pediatric cancer patients, and it's obvious that there are demonstrated benefits of germline testing for pediatric patients with cancer, from potential treatment options to cascade testing for relatives. But what about pediatric patients who themselves have no history of cancer? How do we make sense of balancing the potential benefits of germline testing with some ethical considerations that can help to guide that decision-making process? So in my portion of today's talk, I'm going to be discussing some ins and outs of cascade testing, including when we recommend cascade testing for pediatric patients and how it can be useful and even life-changing for these families. We'll also review some of the ethical considerations to keep in mind when thinking about genetic testing in minors, as well as strategies for overcoming barriers to cascade testing. So germline testing takes place in three main settings. For patients with cancer, NCCN guidelines often help determine who qualifies for genetic testing. So certain patients, like those with ovarian, pancreatic, high-risk prostate cancer, or early onset breast or colon cancer, universally meet criteria for genetic testing. Guidelines don't exist to sort of cover or meet every possible scenario. Patients with pediatric cancers may meet criteria based on their personal or family history, but often clinical judgment must come into play, as Kristen described. Some centers are moving more toward universal germline testing for pediatric or adult cancer patients, given that studies have shown that strict adherence to guidelines-based testing will miss a substantial portion of germline mutations. For patients with a family history of cancer, testing may be pursued if the patient's affected relatives either choose not to have genetic testing or could not undergo genetic testing. Family member may have passed away before genetic testing was done. They may live in a country where testing is not accessible or may just not want to undergo genetic testing. So although an affected relative may be the most informative person to test, unaffected patients make up a large proportion of patients who undergo genetic testing. And under this category, we could also include those who undergo genetic testing via what is essentially population screening. Perhaps there's no known family history of cancer or nothing concerning from a germline perspective. But if the patient is interested in learning as much as possible about future cancer risk, they may still choose to undergo genetic testing through their healthcare provider or even through direct-to-consumer genetic testing, which is becoming more and more available. And the last category, and the one I'll discuss most today, is patients who undergo genetic testing due to a known mutation in their family. This can be referred to as family variant testing, predictive testing, or cascade testing. So why is this such an important topic of conversation? We know that for a vast majority of hereditary cancer predisposition syndromes, first-degree relatives of a proband have up to a 50% chance of having the same mutation. Predictive testing can help us to determine with certainty who in the family does or does not need enhanced cancer surveillance or to undergo risk-reducing surgeries. And there was an interesting study that I came across as I was preparing for this talk. This was model-based research that was done out of MSK that estimated that it would take just 10 years to identify
all 3.9 million carriers of high penetrance hereditary cancer syndromes if there were even a 70% uptake in Cascade testing. I thought that was a really remarkable finding of this model-based study. We know that there's incredible value in germline testing and the subsequent Cascade testing that it enables. Studies have shown that BRCA1 and BRCA2 carriers who are assigned female at birth, for those patients, risk-reducing salpingo-oophorectomy reduces mortality by 70%. And more frequent colonoscopies in patients with Lynch syndrome has a similar impact on colon cancer mortality. So we know Cascade testing literally saves lives through early detection, prevention, and risk reduction. So if we know the potential benefits, why don't we just do this testing for everyone? Some people have suggested that because of the potential benefits, germline testing should be universal. It should just be something that everyone has access to regardless of family history or personal history of cancer. And it's becoming apparent that for cancer patients, the tide may be turning in that direction. As I mentioned before, cancers don't read the textbook. Guidelines-based approaches miss a substantial proportion of hereditary predispositions. But what about unaffected individuals? And what about children? What are some things that we need to keep in mind before jumping to that universal implementation of germline testing in unaffected individuals? So we know that all major professional organizations that relate to genetics or pediatrics in some way recommend deferring genetic testing for adult onset conditions until adulthood whenever possible. Several of the tenets of medical ethics, including autonomy, beneficence, non-maleficence, and justice, all come into play when we're thinking through the decision to test kids, especially for adult onset conditions. Testing in childhood can be thought of as taking away the future adult's autonomy to choose whether or not to know their genetic status, to weigh the risks of knowing against the potential benefits that come with making an informed decision. You also have to think about whether genetic testing provides an actual benefit to the child or if it prevents harm to the child in any way. When a child's care would not change based on the results of that genetic testing, it's difficult to say whether that testing in childhood would actually benefit the child. But as we'll see in a minute, there are exceptions to every rule, exceptions to every guideline. Any potential benefits of testing must be weighed against potential risks, which include genetic discrimination, which can occur in the context of certain types of insurance, as well as things like military service. It's reassuring to note, though, that health insurance and most employment is protected under the Genetic Information Non-Discrimination Act. But other risks of testing during childhood could include less tangible things. Things like causing anxiety, altering a patient's self-image or the image projected upon them by their family, altered expectations from the parent or the child based on this knowledge. For example, is the child going to be treated differently by their parents, protected more if they're known to have this increased risk? Will they be assigned a sick role if they test positive? These potential outcomes of testing can be difficult to predict and difficult to quantify. Typically, Cascade testing for adult onset conditions such as hereditary breast and ovarian cancer syndromes and Lynch syndrome is not indicated in kids because their cancer surveillance would not be initiated until adulthood anyway. All of that being said, though, like I said, there are always exceptions. So one example is, let's say that there is a family with a hereditary breast and ovarian syndrome caused by a BRCA1 mutation. But let's say that there was a breast cancer in the family diagnosed in a person's 20s. Testing may then be considered around 5 years before the earliest diagnosis of cancer in a family, which could put someone into their late teen years and thinking about doing testing before the age of 18. The same principle could apply to a family with Lynch syndrome, in which a person was diagnosed with a particularly early onset colon cancer. There may also be unique psychosocial situations that warrant additional consideration of whether testing earlier may be thought appropriate. So that was the case with the family seen here, in which we had a 16-year-old patient whose mother had recurrent metastatic ovarian cancer and was found to have a BRCA1 mutation. The mother's prognosis, unfortunately, was not very good, And she and her daughter felt strongly that they wanted to know the daughter's genetic status prior to the mom's passing. In extensive conversations with the families, it was clear that they both had seriously considered the potential risks and benefits of testing the minor for this adult onset condition. They felt strongly that not knowing the daughter's genetic status was causing active harm in the form of anxiety that the mother and child were sharing, not knowing whether, not knowing whether the daughter had inherited this genetic change. As part of the counseling process, we used anticipatory guidance to talk through what would it feel like if the daughter tested positive. Would that bring up feelings of guilt? Would they regret knowing that information? How would she cope with that news? The family took a very thoughtful approach to the discussion, had time to discuss it alone, think about it as a family, and ultimately came to the conclusion that it would be beneficial to do the testing at the time, rather than waiting for just 2 years until the daughter was 18. So although guidelines recommend waiting until adulthood to test, there are a certain number of limited scenarios where testing can be considered earlier. There are, of course, many examples of hereditary conditions for which we definitely recommend cascade testing in childhood, given that there is cancer risk in childhood that can be addressed through screening. If screening would be initiated in childhood, then testing is recommended in childhood. So some of the most common examples of when testing is indicated are listed here and include things like Li-Fraumeni syndrome, which came up in Kristen's talk. And another example is familial adenomatous polyposis, which is caused by mutations in the APC gene. This list is, of course, not exhaustive, but I wanted to provide a couple of examples of the benefits of cascade testing in pediatric patients. And I'm going to highlight one example here of an endocrine syndrome, since that's my specialty. This is a family with a hereditary paraganglioma and pheochromocytoma syndrome caused by a germline mutation in the SDHB gene. For those of you who are unfamiliar with this condition, patients with an SDHB mutation have about a 50% chance of developing tumors called pheochromocytomas or paragangliomas, which can secrete hormones that cause symptoms like hypertension and racing heart rate, among other symptoms. When a tumor does develop, it also has about a 50% chance of metastasizing, at which point they can be very difficult to treat. For this family, cascade testing was pursued after the mother was found to have an SDHB mutation. For this condition, testing is indicated in childhood so that screening through whole body MRI can be pursued. Both of this patient's children were found to be positive for the familial mutation, and on screening, one of the children was found to have a retroperitoneal paraganglioma. Screening allowed early surgical intervention, thereby significantly reducing the chance of metastatic disease in this teenager. Another classic example of the benefit of cascade testing can be seen in families with familial adenomatous polyposis, or FAP. This is a condition that causes a high burden of precancerous colon polyps that leads to a nearly 100% lifetime risk of colon cancer without intervention. In this case, the father was the proband. He was diagnosed with colon cancer at age 30, underwent germline testing, and was found to have a de novo mutation in APC, which is consistent with that diagnosis of FAP. Genetic testing is indicated around age 10 in families with FAP, as that's the typical age at which colonoscopies would begin. So his 10-year-old daughter underwent testing first. She was found to be positive for the familial mutation and underwent a screening colonoscopy. And even at the young age of 10, she was found to have a high polyp burden, including adenomas with high-grade dysplasia. She ended up undergoing colectomy to help reduce the chances of developing colon cancer in the future, which is part of the standard of care for patients with FAP who have a polyp burden that can't be managed through colonoscopy. Because of the presence of high-grade dysplasia at age 10, testing was recommended for her younger siblings at that time. 2 of them tested positive, underwent colonoscopies during which adenomas were removed, but no high-grade dysplasia was found. So those siblings will continue undergoing colonoscopies every year or two to manage their polyp burden with the goal of preventing colon cancer. Despite the known benefits of Cascade testing, studies show that only about 30% of eligible first-degree relatives actually undergo Cascade testing. Studies have shown several different factors that influence uptake of Cascade testing, including things like education level, with more highly educated families pursuing testing more often. The gender of the proband has been found to influence uptake of Cascade testing in family members, with female probands being more likely to have family members undergoing testing. And the degree of relatedness, of course, is also influencing that rate, with first-degree relatives undergoing testing more often than second and third-degree relatives of the proband. Of course, family dynamics such as estrangement, guilt, and norms against discussing health matters can also influence the uptake of Cascade testing. There are also certain barriers to genetic testing in general that can have a negative impact on the uptake of Cascade testing. Things like lack of access to genetic testing services, mistrust of the healthcare system, cost of testing, and fears of discrimination can all impact Cascade testing. So what steps can we take to help overcome those barriers and hopefully promote an improved uptake of Cascade testing? Part of overcoming those barriers happens at the patient level, but a huge part of it will also need to happen at a systemic level. On the patient level, it's important to help patients make use of reduced cost or even free Cascade testing that is offered by some genetic testing labs, though not all genetic testing labs offer that type of service. Some labs or cancer centers also offer family letters that can be shared with relatives to help inform them about the options available for them and about the genetic finding that was identified in their family. Beyond that, one of my favorite questions to ask a patient when I've just disclosed a positive genetic test result is, how do you think you're going to explain this to your family? I find that to be a very powerful question because it not only is a useful mechanism for helping to assess their understanding of the finding, but it can help them practice the language that they plan to use to describe this finding to their family. Do they understand the benefits to their family members of doing this type of Cascade testing, the benefits in early detection or cancer prevention? All of those can be useful things to help a patient understand in order to then transfer that knowledge to their family members. That question can also be really useful in eliciting family dynamics that may complicate the disclosure process and helping the patient to brainstorm ways to overcome those family dynamics. This also does not need to be a one-time conversation. I often remind providers that when they're seeing a patient with a hereditary cancer predisposition in follow-up, a simple question of, have you had a chance to discuss this with your family? Has anybody done testing yet? Can be a useful reminder for patients to continue that conversation if they have not had it, or continue the conversation, or to start the conversation if they have not yet had it. On a systemic level, there is still a significant lack of genetic counseling and testing services across the country. Since the pandemic especially, though, many cancer centers and even genetic testing labs directly are offering remote telemedicine services that have improved accessibility of services, but lack of access and cost do remain a barrier. On a federal level, there are two major barriers to genetic testing services that include the fact that Medicare does not cover predictive testing for unaffected individuals. For Medicare to cover genetic testing, the patient has to have cancer. And so this can prove to be a barrier to continuing that cascade of predictive testing in a family. For instance, if a patient's mother and father are on Medicare and they aren't able to do genetic testing for that family mutation, then each side of the family doesn't know who is at risk for carrying that mutation and who else should have genetic testing. And I also wanted to point out that the Centers for Medicare and Medicaid Services do not recognize genetic counselors as healthcare providers, which significantly impacts the ability of institutions to bill for the services provided by genetic counselors. And that can reduce access to those services for patients who need it. So this is my little moment on my soapbox. So I'm going to encourage you all, if you've had a positive interaction, if a patient has had a positive interaction with a genetic counselor, I encourage you to explore NSGC's advocacy efforts to expand our recognition by CMS through the Access to Genetic Counselor Services Act. So looking toward the future in my last minute or two here, I wanted to just point out this study that has been done called BabySeq. This is looking at whole genome sequencing in infancy, and the reason why I wanted to bring this up is this whole discussion is sort of making us all wonder, what does the future look like for germline testing? And so I thought this was an interesting way to close out my talk. So BabySeq looked at whole genome sequencing in infancy as essentially newborn screening through whole genome sequencing. 159 newborns underwent whole genome sequencing, and 17 of them were found to have a pathogenic or likely pathogenic variant described as an unanticipated monogenic disease risk. So most of these were not related to hereditary cancer risk, but it was interesting to see that several of them were actionable hereditary adult onset cancer risks that were found. This testing allowed Cascade testing in the infant's parents, which allowed risk-reducing surgeries for the infant's mothers. But even with the potential downstream benefits, not all patients of infants undergoing this whole genome sequencing even opted to receive the adult onset information. So about 10% of parents declined to get information about adult onset conditions for their newborns. They cited factors that I discussed before, their child's autonomy, anxiety, potential negative impacts on parenting that they worried might arise. So these factors, plus things like genetic discrimination, what do we do with variants of uncertain significance on testing like this? A whole host of other conditions warrant a closer look before we implement any type of universal healthy population screening for hereditary cancer risk. But there will be interesting and ongoing conversations about this in the future, I'm sure. On that note, I'd like to thank you all for your attention this afternoon. I'd especially like to thank Target Cancer Foundation for including genetic counselors and germline testing in this discussion about precision medicine. So thank you.